It sounded like a good idea at the time. Clinical work, I think, will never go out of fashion. How many staff did we have at the company? Me, satu orang, which is great because I was employee of the month and year, every year on year. It's great. I feel relatively unfulfilled. All you need to do is just do it, and then look at your bank account, and that would be pretty good motivation to keep doing it. And I realized after a little while they were kind of right. But if you have a little bit more of a mission, am I really helping a lot of people here? Then, that's when you start to think a little bit further down the line. So I don't think that at any point in time, anybody felt that this was going to replace your doctor. Healthcare, by and large, is a very local business. By its very nature, it is a very local business. We'll end up with a situation of shared or no blame indemnity, shared liability, no blame indemnity. I think by nature, health tech startups don't move fast and break things. I think by nature, health tech startups move fast and fix things.
Join Disruptive Doctors.
I'm Dr. Selena, your host and co-founder of Disruptive Doctors. At Disruptive Doctors, we're building a platform to help doctors like you impact healthcare differently. In Post-Call, we dive into the untold stories of doctors who are breaking the mold, trailblazers who are redefining what it means to be a doctor. This is Post-Call Beyond the White Coat. Dr. Terrence is not your typical doctor. From a medical doctor to pioneering healthcare solutions in big tech, his journey has taken him across clinical practice, entrepreneurship, and now the cutting-edge world of FAANG, F-A-A-N-G. Today, we're diving deep into how he made the leap from doctor to tech leader and what it takes to succeed in this fast-paced world of healthcare innovation. Hi, Terrence.
Hi, thanks for having me.
Okay, Terrence, so before we dive into what you do now, let's take a step back, like way back into the beginning, like before the doctor, before FAANG. Like, who is Dr. Terrence and what the audience need to know about you?
So I like to say I'm a immunologist and primary care physician by training. I trained and I worked in the NHS for a number of years. I'm Singaporean, so I moved back to Singapore after a few years in the UK. I worked in the public sector, the private sector, worked at some NGO, and I worked with ministry for a little while. I've had different roles, predominantly clinical/administrative roles, including transformation roles. And along the way, I started my own businesses. They're not startups. They're more sort of small, medium enterprises that I had started, cut my teeth in business. I sold those on, I exited those, and then I got started in clinical AI through Babylon Health when they were out in this region. I discovered I enjoyed it, and it sort of aligned with my goal of scaling the impact that I have on people's health, because as a physician, the impact is very much one-on-one, which is absolutely required. It is absolutely the bedrock of healthcare. But occupational medicine taught me that I can impact the health of groups of people, and working in technology can scale that even further to larger groups of people. And so I found that to be very much aligned with what I wanted to do. Enjoyed it. I left Babylon after 2 years and joined UB as their global medical director. And then a number of years after that, I joined a big technology company.
Well, it's a very long and sounds like a very interesting journey. But before that, whose idea was it to do medicine?
It sounded like a good idea at the time, is my usual facetious answer. Predominantly, it was always something that was in the back of my mind, right? So I went to United World College, and we have, as part of education, a sense of giving back, of helping people, of working towards a peaceful and sustainable future. Medicine is perhaps one of the more direct ways of doing that. There are lots of other ways, don't get me wrong, that are equally good or potentially more impactful, but that seemed to be the most direct way to help.
What made you decide to leave the UK? I mean, would you say there were more opportunities there than where we are right now in Asia?
So I like to say when I was in the UK, we were hit by something called modernizing medical careers. And that was not administrated particularly well because it was teething problems. And unfortunately, uh, I felt that because of those teething problems, especially as an overseas employee, one might get held back in terms of training, right? So you might have to wait 6 months, 12 months for a better training post. And at that time, I had some family health issues. So it worked out to be better for me to return to Singapore.
What is modernizing clinical work?
Oh, it was modernizing medical careers. So it's it's like a well, not reimagining, but perhaps a reorganization of how training would take place. So now in the UK, you have Foundation 1, Foundation 2, you have all these structures in place. And back then, I think there was just around the start of it. So there was still some teething problems. I don't think it's anybody's fault. So don't get me wrong. I'm not going to point fingers at health secretary or anybody like that. I think it's really just a process that needed to have been executed a number of times before it was smooth.
Okay, so you've worn many hats, right, throughout your career, like what you just mentioned, a doctor, entrepreneur, business leader, a business owner. Now you're in tech. Was there a point where you realized that clinical work just won't cut it anymore?
I don't think so. I still see some patients. So clinical work, I think, will never go out of fashion per se. I think that if your goal is to help as many people as possible, there are various ways to go around that. And one way is public health, of course, right? You scale up your impact. Another way I really feel is through technology and making sure that the technology is correct, is appropriate, is safe, and is deployed correctly. I think most of the physicians here would love it if there were way more physicians involved in designing and deploying the electronic health records, right? Like, honestly, I don't think that it's anybody's idea of fun to go through 20 or 30 clicks in order to be able to order just a chest x-ray. I don't think that's anybody's idea of fun. And perhaps, if there were more physicians, more clinicians who were involved in the whole process right at the start, right before it even hit the hospitals or the clinics, right at the start, we might have been able to make a difference in that way.
Why do you think there's not enough physician involved in like designing the EMR system?
Well, if you've used most EMR systems, okay, I can't put the blame on the EMR systems because many EMR systems or hospital management systems, to be precise, they actually have a large degree of customization that goes into them. And that customization, usually it's done, at least in the past, it used to be mostly controlled by administrative staff, right? And so these days, it's a little bit more of a collaborative effort. So I do see that it's changed. The process of customization also involves a lot of clinicians because they are ultimately your end users and your stakeholders. But in the past, it didn't always used to be that case. And these things would be rolled out. And what you'd end up with is you'd end up with a situation where I'm sure many people are familiar with lots of mandatory fields that is not necessarily the most efficient for a clinical workflow. They work great if you want to generate a whole load of structured data, but I don't think that your physiotherapists, that your nurses, that your physicians are really there and have a duty to create structured data for the system. They're mostly there to serve the patients in an appropriate and optimal manner.
So would this be like a case of an engineer deciding, I think I can automate this and let's just build this?
Yes, but that's also very important, right? So we still need the engineers to say, actually, did you think about having this instead of that? In general, your clinicians will be able to say, hey, we don't want 20 clicks, right? But how do you actually reduce the number of clicks? How do you ensure that it's still safe? What are some of the safeguards? Really, it needs to be a team effort. You cannot just be the clinicians. And I don't think it should just be the clinicians, okay? It definitely needs to be a team effort. So you need the coming together of people who understand the systems, who understand the workflows as well. We also need procurements as well as administrative staff to come in to say, well, actually, do you know, we really, really, really need this bit. Like, we really need ICD 10, 11 code, right? Like, we really need it. And so we're going to make it compulsory. Now, if it was left to many clinicians, we'd rather not have to key in an ICD code, but that's where it comes in, right? So you need the team to say, listen, actually, if you really want to operate then we need these bits of data. And sometimes it's a compromise, but sometimes also it's a case of these are really, really important guardrails and we need to abide by them.
I think that's a very good point you pointed out there, that it's not just an engineer's job or just the clinician's job, but a team effort. Because when I was working in an ICU many years ago, I remember, in ICUs, you have this huge 24-hour charts. They are done manually. You have to write down exactly what's the whole patient's progress, right? You will see all the patient systems all working together. And when something goes wrong, you can look at a chart within seconds, you can tell what's going on. And I remember being in this particular hospital, this huge chart was chopped into 24 frames to fit a computer screen. And when a patient collapsed, nobody knew what was going on. No one could see or tell what was happening. Everyone had to stop work and everyone just grabbed a computer and tried to piece all the information together. It took us some 10 minutes just to figure out what's going on with the patient. So I can see how, whoever developed this really didn't take in the input of the doctors. Why are they doing what they're doing? They just saw, oh, this is a piece of paper, I can digitize it. And it was so dangerous. I remember us not knowing what to do. And when Wi-Fi was down, no one knew what was going on with the patients at all. So I guess there's so much dangers in just implementing something without really knowing what you're doing.
Yeah, absolutely. And I think that, we speak, obviously, disruptive doctors, but I think it goes beyond that, right? So I've been a big proponent of saying, no, don't just get into doctors. That's going to be a disaster. You need to bring in the nurses. You need to bring in the allied health. You need to bring in all the relevant stakeholders into the conversation. Just because something works for the doctors doesn't mean it will work for nursing or therapy. And these are very, very important stakeholders. They are, in some respects, even more important than the physicians. And so I've been using a little bit catch-all term of clinicians, and I'm hoping that will be a little bit more ambiguous, but also allow more inputs, because definitely we need the additional inputs to make sure that workflows are not disrupted, right? And any workflow.
Yeah. Was there any particular incident or experience that you had that you realized that you wanted to do more than, clinic, like you said, right? You still do some clinical work, but then somehow you ventured into business and tech. Was there any particular incident that made you rethink and say, hey, maybe there's something else I can do?
For sure. So I did I did a lot of occupational health as well. So I did occupational diploma, which was great. And it kind of led me to realize that now you're not dealing with just the health of the individuals. We definitely are as an occupational health physician, but you're also dealing with the health of a group of people, right, in a company. And so there are lots of different ways that you can move the needle for a group of patients that would be really challenging to do on a one-to-one basis. I'll give you the example. So for example, if you are in a semiconductor factory, it is by and large a fairly secure area. People tend not to go out. So you have a little bit of for want of a better word, a bit of a captive patient population. And if you really wanted to impact the health, one could always take out any added sugars, for example. You can impact on the canteen. You can say, actually, we're not going to allow you to use X, Y, and Z, right? Like you can't add salt. You can't add sugar. We're going to take away the vending machines for soft drinks, and we're going to all replace it with either sugar-free or sugar alternatives. And in doing that, you can then have a larger impact, because now you're, instead of one people that I'm talking to in the clinic telling them, no, you shouldn't really drink 4 cans of Coke every day. Please drink 4 cans of water instead, perhaps. But when you're doing it, you scale up. So it's now 20 people, 50 people, 100 people, 200 people. And that was when I sort of realized it is possible to do it. And it's not necessarily a requirement to be a public health physician to do it. So if we can do it with small populations in companies, then what can technology achieve? And so you don't necessarily need to be a public health physician to take the handles off water pumps that are contaminated. You can now use technology to have a similar impact. Although we still work very closely, work very closely with the public health physicians, but it doesn't necessarily mean that that's the only way to scale your impact.
Okay, so right after that, you founded Enable Healthcare. you build it up from the ground and eventually exiting in a buyout. Like, could you share a bit about that experience? Like, what made you decide to take this leap, entrepreneurial leap? Was this company bootstrap or you had investors?
So Enable Healthcare is a very traditional SME business. In Singapore at that time, I was working in the private sector, and I felt that, hey, actually, there is a chance I can do a sort of a locum business, right? So at that time, locums were individual contractors, but there was an opportunity to consolidate and to have a simple business model of we can reduce the risk for clinics, because clinics, when you're employing a locum, there's a couple of things that you worry. Will they actually turn up? What's the quality of the locum? And if I need somebody regular, how regular can it be? So we could solve most of these problems with an agency where there's obviously the quality filters. There's also the regularity. So if we say we'll fill the slot for you every Wednesday, and we'll try to use the same physicians, and we can do that because we have manpower. We have an advantage of scale. So that was how it went. We had a couple of great contracts. And then I got sort of sidelined a little bit doing doing my own clinics, as well as a little bit moving into Babylon Health. And that's when I said, you know what, I think it's time to let it go.
Is it easy to start up a business in Singapore?
Super easy. One day. I think it takes you about 1 day to get it registered and everything sorted. It's even better if it's just one person. You can do it within hours. Well, obviously, bank accounts and things take a little bit longer. The admin takes a little bit longer, but it is very business friendly, very straightforward. Yeah, I can do it online. Easy peasy.
Did you have any investors in this business?
No investors. No investors. In fact, I had negotiated the contracts, and then I incorporated on the day that I signed the contract because you want to max. Yeah, they're usually tax incentives for new businesses, correct? So what you want is you want to delay your market entry. You want to delay your incorporation to maximize the tax incentives.
Okay, like, where did you learn all this from? Like, this is how we should do. This is how I'm going to go to market. Where did you learn all this?
I mean, partially because I was in private healthcare already. I sort of understood most of the basics. I understood how operations work. So for me, it was a case of when I understood what kind of business model I could have, I would validate it by approaching various private clinics and say, hey, would you be interested in this? Do you have a need? We can help to fill it. And I would be very honest with them. So, look, I don't have a company yet, but I want to know if you are interested in this, then I'll set it up and we'll do it for you, right? And look, at the start, did I do some of the work? Yes, I did, because I needed to build trust. So I handled quite a number of those slots before transitioning it to other locums. With regards to all the business side of things, we're fortunate in Singapore because most of the legislature is very transparent, it's very easy to access. So a lot of it was just a lot of reading on my part.
Okay, so how much, if you don't mind sharing, like how much do you sell it for? Like what was the multiple?
Oh, that's that. I think I'm still contractually bound not to say, but there's some issues with the problems. There's some issues around valuations for these kind of businesses, right? So by and large, you can't be valued just on revenue. That's more of a brick and mortar business. That's more of a clinic. You get a PE of 3, 4, 5 on your revenue. And that makes sense because you have physical assets, right? With a business like a locum agency, you don't have that many hard assets. It's very hard to do a strict valuation. So what we had done, just to give some context, is really we'd used the value of the contracts moving forward and then take a multiple of that.
Were you running this all by yourself?
Yes.
Wow.
So we were really lean because you don't need a huge amount of staff. But when I say I was running it by myself, I wasn't doing all the locum slots myself. But locums are independent contractors, right? So they independently contract to the company. How many staff did we have at the company? Me, satu orang, which is great because, I was employee of the month and year, every year on year. It's great.
Was it difficult being like Disruptive Doctors? I have a co-founder. Whenever I hit the wall, whenever I feel uninspired, there is another person who I can throw ideas at, brainstorm with, and pick me up when I'm feeling really down. So, what was it like running this all by yourself?
It was actually okay, largely because one of the advantages is when you have a very clear business model and it's just programmatic, right? So you're just churning. And to be honest with you, it's not a bad place to be. If it's programmatic, you're just churning, you get new contracts, and then you churn it. Operations are very programmatic. Like I used to have just a spreadsheet and I would just spend an hour in front of that spreadsheet doing the macros and it would fit everything in nicely. And then undoubtedly some broker will call you up with something and you have to change it manually, but that's just part of the course. But at the end of the day, you know that you are the one person, so all the paychecks come to you. So suddenly doing that spreadsheet is maybe not quite as taxing as it would be maybe like in a big company, right? Because I feel relatively unfulfilled. So the joke was there were a few other folks who also physicians who were doing their own businesses. Some of them were doing sort of clinics, some of them were doing sort of employment or real estate. And I would speak to them and they would go, yeah, you will feel like that, but all you need to do is just do it and then look at your bank account. And that would be pretty good motivation to keep doing it. And I realized after a little while, they were kind of right. But if you have a little bit more of a mission, so after a little while, it also felt like, am I really helping a lot of people here? I'm definitely helping Terrence here, but how many more people am I helping? Then, that's when you start to think a little bit further down the line. And so that's when I sort of nosy my way into Babylon and then sort of shift the trajectory after that.
Okay, tell us about that move to Babylon.
So the move to Babylon was a strange one. It's also a lot of coincidence and luck. So I was tracking Babylon because I still had GMC registration at that time, right? So that's the medical registration for the UK. So they were looking out for locums, and the time difference between Singapore and the UK meant that there was a very attractive locum rate, very attractive locum rate. And so I was tracking that thinking, should I put my name forward? It seems to make a lot of sense. But I was quite busy with Enable, and I continued with Enable for a while, and then they started to gain a lot of traction with the NHS, and that's when I said, okay, you know what, this is pretty big. So I kept tabs on them, and then they signed the deal with an insurance company, and they were bringing the product out here to lots of different markets, and that's when I got to find out that they were looking for essentially what were AI researchers to take on the mantle here, and I put my name forward. It was a little bit of luck as well, because I was one of the few who had done time in the NHS and done time in Singapore. And so I sort of understood a lot of the context behind the UK product that they were trying to localize. So that gave me an advantage in that it was easier for me to do that mental translation, and then I can work on some of the data sets.
Okay, so what exactly was your role there in Babylon?
So Babylon, we were AI researchers. We were helping them to localize the product. And localization essentially means ensuring that it's safe and appropriate, because we use terms here that are used very differently compared to the UK. So making sure that, for example, those things were appropriate. I mean, easy things as well. I can give some easy examples, like the ambulance code may be different. Where you refer patients to may be different. So we were there to make sure that all these things were appropriate and the necessary changes were made.
Okay, so for the viewers who don't know what Babylon Health is, what is Babylon Health?
So Babylon Health was a tech startup. They scaled greatly. I think they had IPO'd as well. So at one point in time, I think they were the largest clinical AI startup by capitalization. They had a number of products. So the ones that people know of were the telemedicine products that were made available, especially in the UK and in the NHS. They had a symptom checker. So it's an online symptom checker or an app-based symptom checker where you answer a series of questions and it will give you the necessary general information around what you had around your responses.
Okay, yeah. So Babylon Health was at one point seen as the future of an AI-driven healthcare, right? With millions of funding and rapid expansion to many countries. And at one point, I think they were valued at $4.2 billion before they came crashing down. Now, you had the opportunity to be working in it. what do you like? Did you see it coming? Like, what was it like for you?
So for context, I left them fairly early on, not super early, but before they went into the US, I'd already left them. I don't think that there was a sense that they were going to run out of money anytime soon. There wasn't a sense that things were badly run. In fact, they had some really good leaders in there. So when I look back at it, before I left, I didn't have any red flags. I wouldn't have said, this is not exactly what I want to do. I don't have confidence in it. I just had a better offer somewhere else. But at Babylon, when I look at it after I'd left, so this is obviously public information. This is my own opinion. This is not based on anything that I had seen or experienced before. When I look at it, I think there was some issues, particularly around the US expansion, because it was, in my opinion, they hadn't innovated on the reimbursement. So it's still from what I understand, it was still a capitation model, which is fairly difficult to make good revenue on, to make good profits on. So I think there was some probably difficulties in cracking the big US market in terms of how do you make a profit from running these businesses.
What is a capitation model?
So in insurance, by and large, you have two major models. There are a few others. You have fee for service and a capitation. So fee for service is basically a pay-as-you-go model. If you pay for the services that are rendered and used, so consultation fee plus, let's say, a blood test plus, say, an x-ray, you would pay a fee for each of these, okay? For capitation models, it's one size fits all. This is the cap. This is essentially you get paid, let's say, 20, 30 ringgit, and that's all you're going to get. That's all you're going to get paid. The minutiae are different, and I don't mean to say that 30 ringgit will cover your x-ray and your blood test and everything, but within a simple consultation, you would have a capitation, so you are only allocated that amount that one can claim. Of course, there are appeals, there are different processes, so obviously a patient who has, let's say, end-stage renal failure is going to have a different capitation compared to a patient who's coming to see you for a minor ailment, let's say like a headache or a cough and cold.
Before we dive back into this incredible conversation, there are a couple of exciting opportunities with disruptive doctors that I want to share with you guys. First, if you're a doctor who's thinking about moving into a non-clinical career but don't know where to start, or even if you're a doctor who's on the fence thinking if you should leave medicine or stay, the non-clinical career pathfinder by Disruptive Doctors is designed specifically for you. The problem why we doctors think that there's no opportunities for us out there is because we've been trained in sick care all our lives, but that's not true. Healthcare is a huge ocean. What you learn in this workshop is discovering yourself, where to find all the opportunities within healthcare, your game plan, and insights from me and Vivek on how to do it. And the best part is it comes with a 14-day guarantee. By the end of this workshop, you gain so much clarity on what you need to do, or if staying in medicine or leaving for non-clinical practice is for you. Our proven framework has helped more than 1,000 doctors on finding a fulfilling career. So stop wasting your time trying to figure it out all on your own in the dark. So sign up for our next workshop on our website. Next, mark your calendar for Disruptive Doctors Annual Conference and Exhibition. It's happening this 20th and 21st of September. This conference isn't about fitting into label. It's about expanding what is possible in healthcare and reimagining the doctor's role in it. This is where forward-thinking doctors come together to drive real change in healthcare. For those who refuse to settle, this flagship event brings together doctors from diverse backgrounds to explore fresh approaches, share ideas, and connect with a community of doctors to impact healthcare differently. Remember to get your tickets on our website at disruptive-doctors.com/conference 2025. And finally, if you haven't already, please download the Disruptive Doctors app. It is a global hub where you can connect, collaborate, share experiences with doctors across the globe, and you don't have to be limited by geography. This is more than an app, it's a movement. So be part of the community of doctors who are impacting healthcare differently. And also, can you do me a huge favor? If you have not subscribed to the channel yet, please be sure to subscribe, because it's subscribers like you that help us bring better guests for you. So whether it's the workshop, the conference, the app, or just subscribing to the channel, be sure to do it now. Now, let's get back to the conversation. Okay, let's go back to Babylon. Babylon had this AI-driven symptom checker and telehealth services. You were employed with them as a AI researcher. So, how well did it work?
The
The AI-driven part of
AI
the
driven part of it. So based on our experience, it was actually great. It was a great tool. What I would say is there's always risk involved. So the one thing that Babylon was really good at was they're really good at looking at risk. So they had a really great approach to risk. Now, there's always pros and cons. You know this. Um, do you know this intrinsically as a physician? But whenever you see somebody, you're always thinking, what is the risk? So if somebody has chest pain, what's the risk that this person has a heart attack, right? They're 70 years old, diabetic, renal failure, hypertension, high cholesterol, high risk. Okay? High risk. But if it's 20 years old, very atypical, been there for 3 weeks, you know that risk is low. But when you have a system that's scaled, how do you then tolerate or transfer some of this risk? Because if you're a physician, you can do the necessary. You can say, listen, you're 20, it's been 3 weeks. Honestly speaking, if there's a heart attack, 3 weeks of heart attack is really you're not gonna be good enough to be walking around, or it's really unusual. I don't think it's that bad. I can do an ECG for you here, and then we can take it from there. We can have an adult conversation over what should be the next steps, right? And you can have that joint decision making with the patient. But when you have a symptom checker, you don't have that. You can't say to the patient, hey, I think your risk is really low. Let's do an ECG. You can't do an ECG, right? There's no integration for that at the moment. And we can't have a reasoned discussion to be able to reach some sort of conclusion. Instead, what you're left with is a fairly hard one-way information delivery system, right? So, you could be at risk. We think the risk may be low. It could be also these things. And by the way, to be safe, you should see a physician because this doesn't constitute a medical consultation. When you say, was it good? Was it effective? I think there are lots of different lenses to look at it through. Was it safe? Yes. Was it effective in giving the patients more information about their health? Yes, for sure. On the other hand, if you're saying, hey, I want to reduce all my A&E visits with this tool, I think the data we need to deep dive into the data for that. But you can see where if you had a more risk adverse system, you might end up sending more people to A&E because you wanted it to be more safe rather than to take on more risk. And to be frank with you, I don't think anybody wants to take on any more risk than they have to. That's human. It's absolutely ridiculous to think that you would take on more risk. But, so that's where you move the sliders in terms of risk and effectiveness.
Would you say that is the main limitation of that?
I would say there were quite a few limitations. So I'm going to switch tack and not talk specifically about Babylon symptom checkers because I've worked on quite a number of symptom checkers. But just symptom checkers in general, they always will be limited by several things. So they're limited by the amount of data that they can absorb compared to a human. So why is this? That's because when you see a patient, you see them. There's a visual input. Even though you're only taking a history, there's a visual input, right? You can tell if somebody's in distress, in extremis, or not really. If they say, oh, I'm breathless, but they're talking really rapidly, really animatedly, they're getting up, walking around, can't be super breathless, right? Probably a little bit. You also, let's be honest here, you also have different senses. So you can smell, you can hear the tone of their voice, the timbre of the voice. Somebody very hoarse, croaky voice. They speak very slowly. They tell you that they're cold. They're cold in your air conditioning. Okay, maybe your room's not air conditioned. They still feel cold. You're thinking, oh, you know what? Could this be hypothyroidism, right? There are additional streams of data that we get as humans that a symptom checker doesn't have that will help us with how we perceive the patient and the information that we gather from the patient. So there is a data limitation. Number two is the patients themselves. So very famously, I do like to quote Dr. House, patients lie. I don't think that many of them lie on purpose or maliciously. I think it is more a case of They might omit things, they might forget things, which is very common. I do that too when if I go and see my specialist. Oh yeah, by the way, I forgot about this. And I'm thinking, oh man, I'm irritated. If I was on the other side, I'd be irritated. So I don't think it's malicious or intentional, but you can omit things. There is a degree of ambiguity. So on some symptom checkers that I tested, not worked on, but tested, you're allowed to click, I don't know. And I'm just thinking to myself, if you just click, I don't know, what will you get at the end? I tried it, and it's classic. It gives you all the usual suspects, right? TB,
Cancer.
hypothyroidism, all the kind of, it could be anything, kind of Addison's disease, famous, right? Addison's, lupus, all of these all came out. So if you click on that, and it allows you to say, I don't know too many times, it's not really gathering enough data. And again, it's not the model's fault. It's probably not the patient's fault either, because not everybody can understand, right? Or not many people can recall every single detail of their health at any point in time. And then it comes to system issues. So when you hit system issues, I think that, again, symptom checkers that I've tested, not that I've worked on, symptom checkers don't deal with the possibility of multiple diseases very well. They tend to try to unify things into a single disease, which is, perhaps one might say, is not unreasonable, because in clinical medicine, we tend to use Occam's razor as well, right? Like if you have this constellation, does it fit into one of these buckets? Addison's, lupus, all the usual suspects? Or can it be 2 or 3 separate conditions in the same person? So I think those are some of the limitations, but on the whole, I think as general informational tools, they work very well.
Do you think those all the symptoms checker, as they were developed, the idea was to replace a doctor?
No. So I don't think that at any point in time, anybody felt that this was going to replace your doctor. I think it was more a case of potential triage. So, because if you're a patient, you want to know, do I need to go see a doctor, or it's nothing, right? That's got a really big use case if you are in a remote area. So particularly, let's say you're in the outback in Australia, I got to travel 4 hours drive to go and see a doctor. I need to know if I really, really need to go and see him. Now, there's certain things that are going to be obvious. I sliced off my thumb. I gotta see somebody. But it's kind of like the edge cases, like, I got a cough, I got a bit of phlegm, right? Do I really need to go and see a doctor? You use the symptom checker to try to help you to reach that decision. I think is not the most terrible of things, but then again, it's always a risk appetite. And I think that in particular, some of these symptom checkers do a good job of trying to convey the amount of risk involved. But as we know, risk is not just 1 in 10 people will have this, right? Like, it's not just the 1 in 10, it's really the consequences as well. So it's the frequency and the hazard, which is what is the potential harm that you could come to, right? So I always kind of say, well, somebody has a acne outbreak, frequency is high, the immediate harm is not enormous. I think most people agree that acne outbreak harm is not massively enormous on physical mental health. Now, I'm sure a lot of people will say, actually, it's got a toll on my mental health, which is not unfair. Again, I don't think going to the doctor will fix that in 1 or 2 days. It's highly unlikely. On the other hand, we took the example of a 20-year-old with chest pain. That could be a heart attack. The risk is probably low, especially if you had it for 3 weeks, but the consequences are really severe if it really is a heart attack, if it's an atypical MI. So I think some of these things these days, especially with newer technologies, we can convey a little bit more of that nuance.
I think I really like how you're saying that symptom checkers are really risk assessment tools, not so much as a diagnostic tool.
Yes. I mean, you can. So on the other hand, there are only 2 hands. So on the other hand, you could argue that can they form the basis of like a quick, I don't want to say diagnostic tool, but a little bit of a quick fix kind of tool. Now, that would be a very different environment. Like if you're in a very remote part of South America or Africa or Mongolia, where you actually have no access to healthcare, or you've got access to very basic healthcare, then you could make an argument that something is better than nothing. Like, if I can't really get to a doctor, then I might as well have something compared to I have no idea what's going on. And for the most part, when you talk about these somethings, you're not talking about a 50 or 60% something. Most of these things tend to be above 70%. And in some cases, when you're looking at, let's say, radiology, right? Radiology tools, some of them are actually 90% somethings. I think most people would say, well, I'd rather have a 90% something for my, for example, TB screening X-ray, rather than have to wait 4 months for radiologists to read it, because frankly speaking, 4 months is really, I might as well not really have the result, right? Like it's not actionable for me. So I think there's a little bit of nuance as well over what kind of environment you are in. Like if you're in a nice, very modern place, like let's say KL or Singapore, you probably don't have a big problem to access to healthcare, right? Like I go to KL and there's a GP clinic around every corner. It's kind of the same in Singapore. You can take a stone and you probably hit 2 GP clinics by throwing it in any direction. So you don't have an accessibility problem per se. There's not an expertise problem as well per se, because they can always refer you on to the specialists who are fairly readily available in these countries. And so how you would use that tool is really, it's 2 o'clock in the morning. Do I really need to go and see him now, or can I go and see him in the morning? That might be the use case in that case, compared to the chap who's in sub-Saharan Africa who really can't get to anybody unless he really makes an effort, and he wants much more information. Then do I need to go and see somebody tomorrow? I probably want to know a lot more into this so that I can make a more informed decision.
Well, that's a very good way to put it, because right here in KL and Singapore, you have so many telehealth companies, and it makes you wonder whether there really is is there that much of a demand that someone could not walk out of the house, walk 10 steps to a clinic?
So I think that it's different things to different people. What I would say is you all have a population who have mobility and access issues, and absolutely that is a game changer for them. Absolutely, right? The fact that I don't need to transfer into my wheelchair, go down, get a specific cab, because your wheelchairs can't fit into every cab, and your transfer boards are not long enough for every cab. And absolutely, it'll be a game changer for them, in that now I have access to healthcare more or less on demand. For example, for sure, there'll be certain things that you still need to take the effort to do, to go through all the steps to go and see somebody in person. But by and large, where you can now have it online is going to be much more convenient. It's going to be much more accessible. Yeah. Again, for the people who live remote, right? Like if they're really out there in Borneo, but still have cell reception, that might also help, right? That could also help you with access to healthcare. On the other hand, if you live in KLCC or near Pavilion and it's downstairs, obviously accessibility is not an issue. But if it's 2 a.m, accessibility may still be an issue, and you can still have a bit of a marginal gain from that. You can also use the telehealth systems to help you triage yourself. So for example, and this is a bit of a silly example, but let's just say I got a bunion. Okay, so I've got a bunion, and I'm trying to figure out actually where do I go? Do I go to the GP? But he's not going to do anything about bunion, right? Like, all right, just do a teleconsult. I don't need to go down. I don't need to expose myself. Obviously, the big use case is COVID. I don't expose myself potentially to infectious diseases, and I can ask the person, look, I got a bunion. Here it is, right? Like, who can I see that they can advise you accordingly? Like, oh yeah, you can see orthopods, you can see there's some podiatrists who can see this for you. It depends on your option. So do you want surgery? If you don't want surgery, you probably don't need to see too many people. Podiatry can help you with footwear, that kind of thing. So again, I don't think that there will be a very low demand for it. I think that there will always be use cases for telehealth. But I think that what is happening is you see integration of telehealth into normal clinical workflows. And I'll give you the example of how I used it before. Was I used very traditional telehealth. It's called the telephone, where results would come in, and look, let's just say for argument's sake, it's a diabetic review. simple diabetes. Okay, I know no diabetes is really simple, but let's just say for argument's sake, it's a simple case of type 2 diabetes. Really, the only thing has been I've just checked the creatinine clearance and just say the HbA1c. There is actually no reason why that patient needs to come down if everything looks hunky dory. So if the HbA1c is well controlled, the creatinine clearance is good, I'm not going to change anything. Why should that patient need to come down to my clinic, wait, queue, come in for me to tell you everything was great, off you go? Absolutely no point, right?
Would you say
So
it's very dependent on the government to, whether that is legally right by the law for you to do a telehealth? Is it based on governments and medical acts around the world, or is there nothing that regulates all this?
There are. I mean, we know that there are telemedicine regulations around the world that determine who can see for what purpose, etc. So very acute things, you're like, no, it's not appropriate. You should go to the hospital. But, if you're horribly breathless with chest pain, it would be quite an effort to make a call to your telemedicine provider. You'd probably be calling the ambulance, but there may still be cases like that, especially where they're caregivers, etc. And so we do need the guardrails. I don't think necessarily that there's a lot of restrictions where the risk is very, very low. So the example that I cited to you where I need to just communicate to the patient, your blood tests are great, carry on, I'll see you in 3 months, is very low risk, right? Because a medical practitioner has seen the patient before, we are familiar, we have the results in hand, we've seen it, we've reviewed it, we do not need to see the patient again to interpret those results or to get more information. And all it is conveying information. As long as we do that in a private and secure manner, I don't think that there are many regulations that will prevent you from doing that.
What about adoption rate from patients? Is it high?
I don't have the statistics, unfortunately, but I do hear of more of people using it. Obviously, uptake was highest over COVID because, I don't want to go out, especially not to a clinic. But even after that, I do hear of a sort of friends, family who do use it.
Before we dive back into this incredible conversation, there are a couple of exciting opportunities with disruptive doctors that I want to share with you guys. First, if you're a doctor who's thinking about moving into a non-clinical career but don't know where to start, or even if you're a doctor who's on the fence thinking if you should leave medicine or stay, the non-clinical career pathfinder by Disruptive Doctors is designed specifically for you. The problem why we doctors think that there's no opportunities for us out there is because we've been trained in sick care all our lives, but that's not true. Healthcare is a huge ocean. What you learn in this workshop is discovering yourself, where to find all the opportunities within healthcare, your game plan, and insights from me and Vivek on how to do it. And the best part is it comes with a 14-day guarantee. By the end of this workshop, you gain so much clarity on what you need to do, or if staying in medicine or leaving for non-clinical practice is for you. Our proven framework has helped more than 1,000 doctors on finding a fulfilling career. So stop wasting your time trying to figure it out all on your own in the dark. So sign up for our next workshop on our website. Next, mark your calendar for Disruptive Doctors Annual Conference and Exhibition. It's happening this 20th and 21st of September. This conference isn't about fitting into label, it's about expanding what is possible in healthcare and reimagining the doctor's role in it. This is where forward-thinking doctors come together to drive real change in healthcare. For those who refuse to settle, this flagship event brings together doctors from diverse backgrounds to explore fresh approaches, share ideas, and connect with a community of doctors to impact healthcare differently. Remember to get your tickets on our website at disruptive-doctors.com/conference 2025. And finally, if you haven't already, please download the Disruptive Doctors app. It is a global hub where you can connect, collaborate, share experiences with doctors across the globe, and you don't have to be limited by geography. This is more than an app, it's a movement. So be part of the community of doctors who are impacting healthcare differently. And also, can you do me a huge favor? If you have not subscribed to the channel yet, please be sure to subscribe, because it's subscribers like you that help us bring better guests for you. So whether it's the workshop, the conference, the app, or just subscribing to the channel, be sure to do it now. Now, let's get back to the conversation. Okay, so right after Babylon, you joined a big tech company, one of the FAANG companies. I think that's a huge step for anyone. A doctor from a medical background, now you're in a FAANG company. Like for the uninitiated, what is FAANG?
Okay, I'm going to get this wrong. The FAANG refers to the big technology companies, right? The term is probably a bit outdated because F used to stand for Facebook, which is now Meta, Apple, etc. There'll be a better definition that I can give you, but it's basically the biggest tech companies in the world.
Okay, and how did you get in?
So what happened was actually after Babylon, I joined UB, which is the Japanese startup, also clinical AI. Joined them as the global medical director, where I was working in back-end development. So I was doing a lot more kind of development work. I was Scrum Master, I was working teams as almost like a product owner, making sure the medical development was safe. I moved a little bit more towards the front of the house on the partnership side, giving the presentations, giving the pitches. And then I got a call actually from my current employer who asked me if I wanted to join them. It was an interesting role, and so I took it up. So now I'm at one of these big technology companies, helping them with their solutions, helping them with their business development as well.
And mostly in healthcare?
I specialize in the healthcare and life sciences vertical.
Okay, so then what are the biggest trends that you're seeing in healthcare startup right now?
So I cover the region. So I cover Asia Pacific and Japan. What I've seen, how I think of healthcare and life sciences mentally is like this. My mental model is like this. Healthcare, by and large, is a very local business by its very nature. It is a very local business. And the vast majority of healthcare startups tends to be gaps based. So they tend to see a gap in the market and they fill it. So it's kind of like there is no big system for telehealth, for example, right? So I'll set something up. There is nobody really does queuing really well. I'll do a queuing solution. The EMRs are terrible. I want to do a much better EMR. It's gaps based. There's a gap. They fill the gap. Absolutely great way to start. Very obviously, you know where your target market is. You understand the steps to get there. But because healthcare is a local business, my feeling is that healthcare startups tend to run into some problems trying to scale. Like telehealth providers, it's unusual, and I think it's less likely that we'll see an Asian telehealth provider scale, let's say, to China or scale to the US. I think most people intrinsically kind of understand that it's difficult. That's going to be really hard. There are some healthcare businesses that can scale, particularly when it comes to more infrastructure platform-based systems. So we're seeing AI scribes come up, and AI scribes are clearly scalable because they don't impact the delivery of services directly. They are more of an indirect tool. So those I do see them scaling. I do see them moving abroad out from the whole region. How I think of life sciences is life sciences tends to be more of a global business, right? You create a new hip implant that's going to be scalable to the US, to the EU, to China as well, because everybody's got hips for the most part. And most of anatomically are very similar, so therefore that product can fit. But life sciences tends to be a little bit more capabilities based. So I'll give you the example. If you want to get into the genomics business, you got to be in a country where you can run sequences, you can have access to sequences, you can have access to your genetic scientists, that you have access to your data scientists who can help you with your variant calls. And so when you look at the healthcare and the life sciences, they're actually a little bit distinct. There's a lot of crossover for sure, but there's a little bit of distinction into how I think these companies come up and how they scale.
So it sounds like if it's a tool, it's easier, but if it's some form of delivery, then it will be geographically limited. Is that what you're saying?
I think if you're directly impacting on care delivery or part of the care delivery chain, then localization is key. If you're a tool, yes, localization is still key, but it will not be a massive blocker.
I think it'll be quite important for any healthcare startups or anyone who is thinking of starting up a healthcare startup, like all these little nuances where to play and how to win.
I think, I don't think necessarily that if you're a startup founder, you will go to the blackboard and say, Terrence said, don't be do this tool, do that. I think that because it's gaps based, I think application or trying to fill that gap in an appropriate and correct manner is going to be the key to success. And success means different things to different people. So I tell a lot of founders, this seems like a great idea. Will you be the next big startup? Will you hit $1 billion of revenue or valuation? Excuse me. I don't think that's very likely, but will it be a decent business? Yeah, absolutely. Right. And so I think that we probably should be at a stage, especially for healthcare, of thinking, how big can this potentially scale? And yes, that is very fuzzy. It's very noisy, but potentially how big can this scale? And would I be happy with that? Are you
Okay.
happy with, I'll give you the example, right? So let's just say, for argument's sake, telemedicine. Are you happy with just Malaysia? Or, and if you're not happy with maybe just Malaysia, you wanted something like the whole of North America as well, maybe telemedicine might not be the best business. But then again, I do counsel some founders, well, what if it's a stepping stone? What if you do telemedicine now and you kind of sew up the Malaysia market, for example, and then you do something else like over in the US? I mean, would that be acceptable as well? So I think sometimes it's around what is acceptable to you, what are your long-term goals, what do you hope to achieve?
Okay, I think that's a very good advice. I mean, where you want to be is not the same as another founder, right? You could have, say that, like what you said, just being based in Malaysia, but I capture the entire market. I'm happy with that. And that's okay.
Yeah, absolutely. And that will inform your decisions moving forward. So how much investor money do I need to take? Or do I need to take investor money? Do I want to take investor money? Right? What kind of deals am I going to strike? Am I going to target the very local berhads, or am I going to go for those really big multinationals that will help to inform your strategy? So I think that I've not really seen too many folks say, oh, I'm very satisfied with just Singapore, or I'm very satisfied with just Batam, most have a aspiration to do something big, to have a big impact, which is always natural, which is part of why people build. But I also think sometimes, especially in the current climate where funding is maybe a little bit difficult to come by, and where we're faced with maybe some trade barriers, perhaps it's probably a good place to start and to kind of say, actually, if we achieve this, I'm going to be pretty satisfied and I can do something else later.
Okay, so AI in healthcare, like the hot topic right now. I think AI in anything, but let's talk about AI in healthcare, right?
Uh-huh.
As it is, doctors, we don't even trust a lab test that's being done by another hospital. We'll always want to repeat it, right? So there's so much of skepticism among doctors. So what do you think is going to be that barrier for doctors to embrace this?
I think in a single word, trust. So you use the example of a lab test from another hospital, right? But let's say you've worked at a hospital and you know that the QC is good. Then you might have more trust in that result. Same for AI. Do I trust the AI or do I not trust the AI? If you have a good high degree of trust, then I think adoption is going to rapidly increase. If you don't have a lot of trust, nobody's going to use it.
Do you build trust? How can you help doctors to build trust on your AI system or model?
I think there are two ways. It's getting increasingly difficult because of the technologies that are being used. So I'll go into that in just a little bit. But by and large, if you're looking at very traditional AI models that are deterministic, that is, they're not generative in nature. There's a simple way to put it. The old school AI, it is explanatory. So therefore, you can, if you put in this data or this input, you're always going to get the same output each and every time because that's how the models are built. In which case, then it's an accuracy thing, right? So you show that the model works and works under all of these conditions, and these are the statistics. This is the accuracy. This is the recall. Whatever. And that's a really good way and straightforward way to build trust, right? It's exactly the same way as, to use a stupid example, the syringe. The syringe, you press it, it goes. It works, right? Each and every time. And as long as you can prove that in a good study with enough patients, statistically valid, then for the old school AI models, that's one way to build trust. Very much more straightforward way to build trust. And then you'd have deployment, you'd have very, very close follow-up on the adoption to figure out, are there any errors? If they're not errors, then that's fine. Can build a lot of trust that way. But the problem these days is when you're using technologies like generative AI, which is non-deterministic, that is, the same set of inputs will not give you the same set of outputs each and every time, then it's a little bit more difficult. I know that there's some assessment tools that have been published more recently to say, hey, these are the things that you need to look into. But I think just in general, we don't have a very, very, very good idea of how to truly assess some of these models.
What do you think is the biggest misconceptions about AI in healthcare?
I'm going to be a bit weird here. And I'm going to say the misconception is that it won't take over people's jobs, or it will take over people's jobs. So, and that's a really strange thing to say because it's super contradictory. But I think that what's going to happen is that it's not going to take over a lot of people's jobs fully. But at the same time, I think that there are certain people's jobs that will be greatly disrupted by it, so as to essentially mean that instead of a team of 10, you just need a team of 1 or a team of 2. Now, when I talk about healthcare, I'm talking really top to bottom. So I'm talking portering to administration, to CEO, the whole stack, everybody that works in healthcare, because AI is really great at some of the automation processes. And when you can automate certain processes, then suddenly, do you need somebody to do the roster? Do you need now somebody to transfer these bit of data into an Excel spreadsheet? So I think that some of these roles will get disrupted. I don't think that they'll lose their jobs, but I think that jobs will change. And we saw this previously. So we saw when it was still the paper notes, right? You'd have porters predominantly go down to medical records to get the case notes, bring it up to the ward, and they sit there on that stack, and then they'd fall over and knock over your coffee and all that kind of thing. But now that it's electronic, nobody needs to do that anymore. But instead now portering is more around moving the patients physically from location to location, really, really urgent blood tests and like tissue samples, they'd be portering it from one place to another. So has their job been disrupted? I would argue yes, but it's just shifted. So they're doing different things now. And I think that that's really on the horizon for some of these roles in healthcare. And I think, therefore, what we should be really looking at is doing a really critical look into what are the things that can be made more efficient, and how can we move the right manpower to do different things that is more fulfilling for them and more fulfilling for patient outcomes as well.
As you mentioned that, I imagine myself being a patient on the bed and being transported, say, to the OT.
Mm-hmm.
I mean, there are already robots that can move beds when you do not need people to move. You don't need any manpower to transport a patient from one place to another. But just being the patient, you're moving there all alone. There's no human. There's just this robot that's under your bed. That's just bringing you from your bed, your ward to the OT. There's no human. I mean, going for an operation is probably one of the scariest things, right? Going under anesthesia into this cold OT room. I guess you would want some sort of human interaction, even though it's a stranger, but a warm body there, moving along with you from the ward to the OT. It would still be comforting somewhat. So would you say that, I guess that's where people would be, no longer doing all the boring automation work, but really in places where it requires human touch, human connections?
Yeah, absolutely. And, for you, in the example that you gave, the robot will move the bed now. But now the porter will not be pushing the bed. Porter will be doing different things, right? You can train them up, having as a patient advocate, how are you feeling? Is it okay? We're going to this place. Here's what will happen next. Or you could switch roles a bit. So you can now send an enrolled nurse along, right, to give the necessary information. And the porter, instead of pushing that bed from the ward to the OT, can be doing different things. So that porter can now be helping out perhaps with different tasks like urgent samples, etc.
Yeah, I think that's a really good way to relook at how all this is going to help improve the processes and make it more efficient and possibly do better for our patients?
Yeah, I think that there's a lot of talk around efficiency. There's certain things where you don't want to have a very clear-cut efficiency scenario, like the human empathy part. Like, that's absolutely not what you should be aiming for. But there are certain portions where you want a lot of efficiency. Automated messaging, for example, right? That can be a game changer as well. But at the same time, I think that what we'll probably see is we'll probably see a future where at the end of the day, it comes down to liability as well. So, how much liability rests on the person or the tool is going to inform us how we need to organize some of the services around it.
Okay, it's interesting you're bringing up liability. So that would fall under, I suppose, regulatory, correct?
A mixture. I think a mixture. So the one thing that a lot of people talk about is, this X-ray tool auto annotates this X-ray, but it still needs a radiologist to approve it, right? So therefore, at the end of the day, where does the liability rest? The liability rests on the radiologist, right? That's very clear-cut in this case. But at the end of the day, if you're a radiologist and the liability rests on you, how much checking will you do of that X-ray? I would argue because you have the same amount of liability, if not maybe a bit more, you're going to spend as much time on it, is my gut feel. Everybody's a little bit different. So some people may be willing to take on a little bit more risk, or some people may have more trust in the system. But if it came down to me, I still hold all the liability. So how will that affect me? Not much. I'm still going to check it, right? And then I will approve the annotation piece. Now, on the other hand, I believe that, and I might be wrong, so please feel free to correct me, but the WHO did come up with some guidance to say, hey, if in TB screening, in X-rays, TB screening X-rays, if there's no available radiologist to read the film within a certain period of time, then we recommend the use of an autonomous system, wholly autonomous system. And so then that liability piece is obviously not on a radiologist. He's never even seen the darn film, so he can't be liable for that. But where does that liability sit? Does it sit on the health system who has adopted the AI system, the AI reading system, or on the AI system itself? Because that's the one that's actually reading the films. Now, in those circumstances, I think it can be a shared liability or a no-blame indemnity, because at the end of the day, this is one of those cases whereby, well, if there wasn't this system, you'd wait 4 months, and nobody wants to wait 4 months. So people would probably tolerate that degree of risk.
So what do you think the future is going to look like in terms of all this liability or AI tools working hand in hand with clinicians?
I think that most likely we'll end up with a situation of shared or no blame indemnity, shared liability, no blame indemnity. Depends on the exact solution. I think there are a lot of the devil's really in those details, but you'll probably see a case of maybe a little bit more shared liability moving forward. I also think that increasingly you probably move the liability plane of access. So how do you shift that? You shift that by telling patients that we are using a system to automate. There are some risks in it, and these are the risks. And if you consent, then you agree that these are the risks, and et cetera, et cetera. But then you'd also have the option to say, hey, if you didn't want to use this, then these are the other risks, and the cost may be different, for example, right? But that's really hard to quantify as well, because how can you say that Terence has X amount of risk of getting the diagnosis wrong? It's very hard, I think, to quantify that at the end of the day for humans, but you can lay it out in fairly general terms, right? Like to say that this is the accuracy of the AI system, this is the human. We know that we are error prone, but we can't quantify it. So therefore, it's a bit fuzzy, but we need to tell you, and you still have the choice.
Okay, that's very interesting thinking about it, because I guess it's very exciting now. We're at the start of this, and that's when all this questions will come up, and I think probably more will even come up in the future.
Uh-huh.
In tech, there's this very famous saying by all those big tech founders, move fast, break things to innovate. But in healthcare, mistakes will cost lives. So, how can healthcare startups balance the speed and safety in innovation?
I think by nature, health tech startups don't move fast and break things. I think by nature, health tech startups move fast and fix things. And so, what I think is really key is to have the right amount of expertise and the right amount of stakeholder engagement to make sure that when you fix something, you don't break something else, right? So, and that's really only possible when you have the appropriate professional advice, shall we say, appropriate professional advice, and also the right stakeholders to come in and to trial it to say, yeah, this worked really well, but it totally broke my workflow, or it totally caused a problem with this other thing. And so starting small and moving quickly is probably the way to go. So I don't think that moving quickly necessarily breaks things a lot, but I think moving quickly and not getting the right inputs and not iterating correctly will break things.
Okay, what are the biggest regulatory and technical challenges that you see in all these healthcare startups these days?
So I think it's mostly around the use of generative AI. So we've seen a lot of startups try generative AI in various places. My personal thinking is that if it's not directly related to clinical work, it's fine. It's not a big problem. But when it directly relates to clinical work, then I think that there's going to be a lot more questions in the future over whether some of these tools will be medical devices or not. Will they be more assessed on their function as opposed to intention? And how do we really assess some of these generative AI tools? I think we're beginning to look at models, and very intelligent people, far more intelligent people than I, have come up with some frameworks. And I think that really time will tell on those frameworks.
What's the difference between function and intention?
So there is a little bit of debate going on around some of these general chat tools that are powered by generative AI, because obviously they're not intended to be a medical device, right? Like they're not intended specifically they're not trained specifically to take in a raft of data and then give you a diagnosis and give you next steps. But functionally, some people have managed to do that from some of these tools. I've not been able to recreate it, but some people have, and taken some of the screenshots, and they say, well, actually, it's asked me for very personal information. It's given me some personalized output. So, it's getting close, like if not already there. And so how do you reconcile the fact that it's really not intended? And I don't think the makers ever intended it to be like this. And there are still some disclaimers and safeguards say, no, you shouldn't use it as a medical tool. But functionally, it can be used. The question is, does it still need to be regulated as such? And one of the things is that the regulations on the whole have come up through the years of mostly physical medical devices, because obviously you could use a screw to fix a fracture, although it was never intended to do so. But I think in the digital world, it's a lot different, right? It's not so obvious that I won't put this rusty screw into my toe, as opposed to I'll use this tool that seems really intelligent, and people tell us that, right? Like it's got billions and billions and trillions of data sets inside. I think that probably needs to be re-examined. I don't come down on one side or the other. I think it's really a conversation to be had amongst, I think, society as well as the professionals.
Okay, so how should doctors adapt to a world where AI and automations will be taking over parts of their roles?
In my view, it's always based around how does it affect the patient. So if it doesn't affect the patient, like let's say it's a light touch one, like I say, I want to see you in 3 weeks, and it automatically books an appointment in 3 weeks. Probably not the highest risk, but if it's directly like a clinical decision tool where it says, hey, it could be a nasopharyngeal cancer or something like that, then you would really need to have a high degree of trust in that. And I think one of the things that we have relied upon a lot of in the past are regulations. So has it cleared the regulation? If it is a regulated product that is approved, then you have a degree of trust, right? You say, it's gone through all the steps, it is approved, I'll use this hip implant, I'll use this ECG machine. With the digital tools, because it moves so fast, I think the onus is a little bit on the clinician to understand some of the key factors, there will probably be organizations that will start to look into them to say, hey, we can be that independent voice to say we raise concerns over this tool, or actually this tool we assessed and works very well.
Okay, I like how you always see throughout the conversation, you've brought this up many times. What is the risk? What is the risk assessment on this? Every action, what is the risk on this? So I guess it gives a different perspective, because there are some spaces you talk about what's the probability of this, right? But this is like, okay, what is the risk of this? If I took this action, what is the risk from it?
Yeah. And because the thing is that I come from the headspace of what we're doing now is, it may not be optimal, but it's in inverted commas the gold standard, right? You can think of it as the gold standard, okay, in inverted commas. So therefore, anything coming in, you then need to think, will it be equivalent and faster, in which case it's better, or is it superior, or is it inferior? So it's always a risk when you're adopting something new, in my opinion.
Okay, so what advice would you give for doctors who want to enter the health tech space, but they don't know where to start?
Well, there's lots of organizations like Disruptive Doctors that can help you. There's also now a lot more organizations within organizations that you might be able to explore. So many of the hospitals will have innovation wings or translation wings. Many universities also have incubators, accelerators that you can approach to help out. You don't necessarily need to build right from the start. You can just be one of the advisors. You can go in just as a participant to see what it's about. And I think these represent a lot of opportunities for clinicians to get experience into the field without jumping in, without giving up your day job. You can still experience it. You can understand a lot about it before you choose to move.
Okay, what are the key skills that a doctor needs to develop if they want to transition into tech?
So I get asked this quite a lot. And for context, I was preparing like my manuscript for my opus, my book, my grand opus. And then I just got fed up of looking at the same draft like 50 times in a week. So I split it up into a little bit of a blog. But what I think is key is actually you don't necessarily need to have a huge amount of technical skills. So there's a lot of people that say, should I learn how to code? Should I learn about product management? And my response is, if you want to learn, great. It's always going to be good. It's not going to do you any disfavors to learn these skills. But at the heart of it, you are coming in as a clinician. So your table stakes value is either at the clinical experience stage or the clinical technical plane. So the clinical technical plane could be especially helpful for like devices. Like if you want a guidance system for setting an IV plug and intravenous access, then having done that blasted thing 50, 100, 1,000 times would put you in a great situation, because you can say, we need to swap first, we need to do this. Things that may not be immediately obvious if an engineer, for example, just watched a video of. On the knowledge plane, it is the fact that, let's say, setting IV plugs, you need to understand about, let's say, the indications. You don't set an IV access willy-nilly for everybody. And so maybe what are the indications of that? So these are the things that you bring that are unique, that are more unique to the team, right? And if you know how to code, if you know how to product manage on top of that, that's great. That's perfect. That's awesome. But don't neglect the table stakes where of your expertise that you are bringing in, because you can learn how to code, but let's be honest here. Are you going to beat the full stack who's been coding for 5 years? Unlikely. You might have a flair for it, in which case then I have nothing to say, but by and large, there are the specialists for that. Just like you wouldn't expect the person who is a full stack developer who's been coding for the 5-10 years to understand all the little minutiae of setting an IV access. That's not the expectation there. So focus on what you're great at. If you have passions and you feel you want to expand out, absolutely, you can do that, and that will value add, but that should not be the basis of what you're bringing to the team.
Okay, and for doctors in KL and Singapore, can they join you at Tech Brews?
Yeah, absolutely. So thanks for the plug. Tech Brews is a not-for-profit community that meets outside of office. That meets outside of office hours. So Tech Brews is a pro bono free volunteer-run community. We meet after office hours very regularly. We welcome all. So we work on the basis of being an inclusive and interoperable community for healthcare and life sciences. So you will find people who are founders, you will find people who are advisors, you find long-time compliance and regulatory people from big enterprises there, all the way to investors as well, and people who are interested in the space. You're more than welcome to come and join in on any of our meets, and we're happy to share the link accordingly. It's in Singapore. We're hoping maybe KL. I'm looking at Selena knowingly. We are also in Shenzhen, Hong Kong, San Francisco, and Tokyo. So if you're in town, even if it's for an event, feel free to look up on the calendar, and it's a great place to network and to understand the ecosystem.
Okay, so now this is a final question that we ask all our guests. How do you see yourself impacting healthcare differently?
Oh gosh. So working at technology, it's really enabling the people who build, right? So we're with technologies that are developed at the sort of base infrastructure, fundamental levels, whether you're working on Gen AI models or you're working on computer vision, I think that I'm hoping that to inspire, to be able to facilitate people to and help them to build, and with those tools to impact on patient outcomes.
Okay. Now, thanks, Terrence. If you guys have been enjoying our conversation and considering exploring new career path, remember to check out our non-clinical Pathfinder workshop by Disruptive Doctors. And also do check out our annual Healthcare Disruptive Doctors Conference 2025 that's happening on the 20th and 21st of September 2025, where like-minded doctors like you come together, share ideas, and impact healthcare differently. Also, do download Disruptive Doctors app and connect with doctors all across the globe. And also do check out Terrence's Tech Brews every Saturday in Singapore and possibly in KL. Until then, this wraps up another episode of Post Call Beyond the White Code. I'm Dr. Selena. Take care and keep disrupting the norm.
Join Disruptive Doctors. Oh, Disruptive Doctors. Impact.